Okay. Good evening. Welcome to all to the monthly grand rounds of ASGK. I hereby invite our President Joshi John to start the official meeting.
Welcome everyone to the next round of ASGK Grand Rounds. Without any further introduction, we'll go on to the quiz case by Dr. Arun AML and followed by the case presentation from KIMS Trivandrum. So over to Arun M.
Hepatocellular, can you see my slide?
Yeah.
Okay. Thanks to our team. Thanks to Joshi sir, Dr. Ramachandran Menon, President and Secretary of ASGK, and Pidambaran Murali, our academic coordinators. And for the quiz, one question. Complete details are in a single slide. Type your answer. It should be a complete answer. It can be one word or a phrase in the Zoom chat box as personal message to the quizmaster. Please don't reply as a group response. It's in the Zoom chat box. Type your answer as a personal message to quizmaster, myself, Arun Kumar Ammal. So keep your chat box ready. Answer to Arun Kumar Ammal. Only one prize. The first correct answer in the personal message chat box will get it. Results will be announced at the end of the grant academic discussion. Quizmaster's decision will be final. Please open your Zoom chat box and select Arun Kumar Ammal to type the answer as personal message, not in the group. Pitabaran, clear? Shall we go to the question?
Yeah.
Last time it was a radiology based one. This time I thought we will go back to basics. This is one step one step of surgery in case of transhiatal esophagectomy. So you completely mentioned the name of this particular step. You can see the gastric tube, gastric conduit being made. It can be an optional step, but it's one of the common steps done during a transhiatal esophagectomy. Back to basics. What is the name of this step? Playing the video once again. This is an open transhiatal esophagectomy. One particular step is being demonstrated here. The complete name of this particular step of surgery. Please type as a personal chat box to Arun Kumar Ammal. Thank you so much. Back to Pidambaran.
Joshi sir, come on.
Yeah, you can get. Hello? Yeah.
Hello?
Yeah. Now we move on to the academic discussion of today, this evening, and that is to be presented by the resident from KIMS Trivandrum, and the moderator is none other than Dr. Sudhindran. So, Dr. Sudhindran, please take over.
Yeah, sure. Yeah, please carry on with the presentation. So, Joshi, how is the presentation? We'll allow him to finish the presentation, then ask the questions, etc. Right?
Yeah, that is
grand rounds.
Yeah, in between, I think it would be preferable if people have questions, they can put it up in the chat box so that you can see the questions, and there may be several questions which may be repeated or common questions for which common answers.
Okay, that's fine. Okay, Dominic, are you there?
Yeah, I'm Dominic. 1 minute. I'm going to mute all, so you can unmute and start. Dominic, you can unmute and start.
Hello.
Yeah, we can hear you.
Is my screen visible?
Screen is visible.
Okay. Good evening, teachers. Today I'll be presenting the grant rounds for this month. I'd like to thank ASGK and KIMS for giving me this opportunity. Dr. Sudhindran for moderating. So the case that we have selected is a 53-year-old man who presented with complaints of abdominal pain since 1 year, which was in the right upper quadrant. It was a vague, dull aching kind of pain. He had a loss of appetite and a loss of weight of around 20 kilos. He has no history of jaundice, hematemesis, or melena, no abdominal distension. He has no significant past history and no history of surgery in the past. He has no past history of jaundice. He has no family history of malignancy or liver disease. He has no personal history of alcohol intake. The patient was evaluated elsewhere. An ultrasound abdomen was done, which showed a large lesion in the right lobe of the liver with mildly increased echogenicity of the parenchyma. The labs showed a normal liver function test, negative viral serology, an mildly elevated AFP of 33. CECT abdomen was done, which showed a large lesion in the right lobe of the liver with an enhancement in the early arterial phases and washout in the later phases. A biopsy was also done, which was inconclusive. The patient was deemed unresectable and he was put on supportive care. He took alternative therapy for 1 month, but because he had persistence of symptoms, he came to us for a second opinion. On examination, the patient was well built and nourished with a BMI of 22.3. He was good performance status ECOG1. He has no pallor, icterus, lymphadenopathy, or pedal edema. There were no signs of liver cell failure. On examination of the abdomen, the lower border of the liver was palpable. It had a smooth surface. Other systems were within normal limits. The CT that was taken outside, we reviewed in-house. The liver parenchyma showed a slightly wavy surface, which was suspicious of an early CLD. The lesion was a large lesion in segments 7 and 8, which is extending into segments 5, 6, and the caudate, and a suspicious involvement of segment 4. You can see the lesion. There was arterial enhancement and portal and delayed phase washout suggestive of an HCC. This is just a recording of the portal phase. You can see the large lesion very close to the left pedicle as well. So it was noted that the portal vein was splayed and the right portal vein was compressed. The hepatic artery was splayed. The right hepatic vein was not seen. The middle hepatic vein was compressed and pushed to the left. There were small insignificant perihilar lymph nodes. There were no distant metastases. And we calculated an FLR that might come about if we were to do a right extended hepatectomy. And this came to a very small 18%. That is the left lateral lobe. So he was investigated in our hospital. The platelets was low borderline, 1,40,000. AFP was 34. Otherwise, the liver function was normal, as was the INR. Viral serology was negative. OGD was done and no varices were noted. The case was discussed in a multidisciplinary tumor board. So we had a patient with an HCC and we wanted to attempt curative intent treatment because the patient was a relatively young man with good performance status and no comorbidities. The tumor was large, but it was solitary, localized, with no vascular invasion, and it had pushing margins, not an invasive margin. The liver function was preserved, except there was a borderline low platelet count and the imaging showing a slightly wavy surface of the liver that made us suspicious of an early CLD. So the curative intent treatment in this case would involve an extended right hepatectomy because the MHV was stretched and segment 4 was compressed. So our concerns in this patient was that the FLR for an extended right hepatectomy was only 18%, and we had a suspicion of early CLD. So if we were to go ahead with resection, we would have to augment the FLR before proceeding for resection. The patient was seen by interventional radiology. So the difficulties they had was basically the position of the tumor, an FLR which was very low, and a regenerative capacity that was uncertain. In this case, the PV may take time to produce a sufficient response. And in that period, there is a possibility of tumor progression. And here, as you can see, even a small increase in size would actually lead to an invasion of the left pedicle or the left hepatic vein. And this would make the patient inoperable. So at this point, we had 5 questions facing us. 1, can parenchymal preserving surgery be done? Can we preserve segments 4, 5, and 6? Should we do a HVPG at this point? Should a biopsy of the FLR be done to ascertain the liver status? Should we embolize segment 4 along with the right lobe? And can we do anything to prevent tumor growth in the interim period? So can we do parenchymal resection? Parts of segment 5 and 6 here, they appear tumor-free. But the right hepatic vein was obliterated. The middle hepatic vein was splayed. It was compromised and would most likely have to be removed. The right anterior portal vein was also obliterated. So as the inflow and the outflow are compromised, segment 5 and 6, it is quite unlikely that we would be able to retain it. Now, most of segment 4 was actually appearing free. Here. But the segment 4 was actually compressed by the tumor. The MHV was pushed to the left and splayed. And the segment 4 pedicles, they were also closely abutting the tumor. So even though they were not involved, our concern was that if we try to preserve them, we might end up compromising on the margins. In that case, the surgery would be futile. Now, should hepatic venous pressure gradient be done? The patient had borderline platelets and imaging findings were suspicious of an early CLD. So this could actually add to the preoperative evaluation. But we done an OGD which showed no varices. And the issue is when we're doing a venous pressure gradient in a patient with a large liver lesion, this will be pressing on the hepatic veins, and this can lead to false readings. And it might be technically difficult also to do this. So we decided to proceed without a HVPG. Now, should an FLR biopsy be done? So the concerns that we had here is that we had a small FLR, and if we took a biopsy and if there was a risk of injury, we could not proceed with a curative treatment. And the patient had a preserved liver function. The FLR at this point was 18. So even if the liver function, even if the liver was completely normal, it was still too low to proceed with surgery. So we decided to assess the dynamic response, that is the regeneration after portal vein embolization. And the question is, should segment 4 embolization be done along with the right lobe? We were keen to get this segment 4 also embolized. The advantages for us is that it would lead to a better hypertrophy of segment 2 and 3. This would avoid hypertrophy of segment 4, which would actually increase the transection surface and would lead to more bleeding. And we thought it might actually reduce the progression of the tumor in segment 4. The disadvantages, and interventional radiology was not very happy doing this because the portal vein was splayed and the anatomy was altered. So Sir thought it might be difficult to cannulate the segment 4 branches. And there was a concern that if there was a spillover of the embolization agent, this might actually damage the FLR. We felt that the risk was undue, and it was decided to proceed with only embolization of the right lobe. So then we had to deal with this question. Could we do anything to prevent tumor growth in the interim period while waiting for the FLR regeneration? So the options were a TACE before the PVE, a bioembolization, that is hepatic vein in the portal vein, or an ALPS. But in this case, we only needed a modest amount of hypertrophy. And we wanted to limit the morbidity, which may prevent a curative resection. So we decided to proceed with a sequential TACE and PVE. The PVE was a super selective embolization of the right lobe, and we plan to spare segment 4. The TACE would be done just to prevent the progression of the tumor in the waiting period. So a taste was done on July 23rd. It was a conventional taste with 75 milligrams of doxorubicin. The patient had multiple arteriovenous shunts, which led to dye and drug runoff. There were no other feeder arteries. The dominant feeder was intubated with a microcatheter and was embolized with doxorubicin and lipidiol emulsion. A large quantity of gel foam was needed to embolize the feeder artery. Now, as the lesion was very large, it was very vascular with AV shunts, and the doxorubicin that we normally use is 75 milligram. We did not expect a dramatic response. The post-op period was uneventful. This is the angiogram. You can see the tumor blush. This is the right hepatic artery, which is arising actually from the GDA, from the SMA. And the right hepatic artery was grossly enlarged compared to the left. You can see the feeding vessels, and you can see it's a very vascular tumor. And this is a distal runoff. Post-ACE, there was no forward flow in the right hepatic artery. So why did we use a conventional TACE instead of a DEP TACE? So this has certain advantages in a sequential TACE PV. One, it is a lower cost. The efficacy has been proven to be equal. It has a peak action in 12 to 24 hours instead of 12 days. And the main action of a DEP TACE is to provide prolonged drug levels, even up to 6 weeks. And here we only needed a temporary action. So we followed up with a PET CT after 1 month. This showed multiple areas of non-enhancement suggestive of necrosis. You can see here. The disease remained localized. There was no extrahepatic spread. By MRSS criteria, this was a partial response. And the standardized FLR was calculated to be 25.7%. This is the PET CT images again. You can see areas of non-enhancement and increased SUV uptake. So the case is again discussed in a multidisciplinary tumor board. The patient was responding well to treatment. There was no complications. Liver function was stable. There was good tumor biology, evidenced by the fact that it had remained localized. There was no disease progression. The MRSS criteria showed at least a partial response, and the margins were pushing. And now we had a standardized FLR of 25.7%. So here the question that was raised is, should we proceed directly to surgery at this point? Or should we augment the FLR with a PV as we had planned? Now, 25% is still a borderline liver volume, even in a normal liver. And this, we had uncertain regenerative capacity, and we still had close margins. So because of this, we decided to proceed with the PV as planned. So PV was done on 2nd September. This is the photogram. This is the main portal vein, and you can see that the right and left branches are splayed. And you can see an area where there is devoid of portal vein supply, which corresponds to the tumor in the right lobe. Okay, so we took the ipsilateral approach. Here, the right anterior portal vein was actually obliterated by the mass. So the only approach that we had was the right posterior portal vein, which you can see here through the segment 6 in this diagram. So the right portal vein branches were embolized with N-butyl cyanoacrylate with care to avoid reflux into the left portal vein. What you're seeing here is actually a caudate branch. Now, this is the post-procedure film, which shows a die cast in the right portal vein. And this is the caudate vein branch. And the post-op period was uneventful. We took a follow-up CT after 3 weeks. So here you can see the arterial enhancement and the washout and the pushing margins, which is well encapsulated. You can see the embolized right portal vein with no forward flow. This is a coronal section. Here you can see the tumor. And this is lipidiol in segment 5 and 6 and in the caudate. You can see that the tumor is actually abutting the main portal vein and the left branches also. This is the middle hepatic vein which is splayed and compressed by the tumor and is pushed to the left. This is the left hepatic vein. Here again, the middle hepatic vein, the left hepatic vein. And this is a coronal section where you can see the MHV LHV junction, which is actually preserved. Now this is the arterial phase CT. You can see the well encapsulated tumor with arterial phase enhancement. This is the portal phase CT. You can trace the right portal vein with no forward flow. I'll just play that again. So the portal phase CT, the tumor. You can trace the right portal vein and it's ending there. Next is venous phase. You can see the MHV and the LHV. MHV is splayed and compressed, pushed to the left. Now, these are the pre and the post PV pictures. And you notice that there is just a modest degree of hypertrophy. Now, I've just put this to show that the segment 4 has actually hypertrophied. So this is one of the disadvantages when you avoid segment 4 embolization. The segment 4 actually enlarges, where what we wanted is a segment 2 and segment 3 enlargement. So how do we calculate the FLR? So there are two methods. One is the conventional method and the standardized method. The conventional method is based on the total functional volume of the tumor, and the standardized method is based on a total estimated liver volume. This is calculated on the body surface area. So before describing the liver volumes, I'll just recapitulate the treatment that the patient had. The imaging. So initially there was CT in July. The patient underwent a TACE in August, had a PET CT after that. 3 weeks after this, there was a portal vein embolization. And 3 weeks after that, we did a follow-up CT. Now, this is a slide where I'll explain the tumor volumes. So if you look at the initial CT, the FLR, which is the left lateral lobe, was only 18%. Now, it has been demonstrated that this is prone to error, and this is a CT that was taken from outside, which we use in our software. But this was quite low at 18%. We did a TACE, and following that, there was a CT. Here you can see the total liver volume is 2,300 ml. The tumor volume is 955 ml. The volume of the left lateral lobe is 354, which corresponds to an FLR of 23.4. Following PVE, we did a repeat CT, and in that, you can see that the tumor volume is actually increased. This expansion happened in a phase of 1 month, and we discussed this with the radiologist, and they feel that this could actually be an error in computation. The left lateral lobe had increased, but if you look at the difference, it's actually only 80 ml. But when we calculate the conventional FLR, this shows an increase by 16%. Now, this increase is actually a fallacious increase. The absolute volume increased by only 80 ml, but the conventional FLR calculation puts it at 40%. Now, this has actually happened because we calculate tumor volume in the denominator. So that is the advantage of using a standardized FLR. So when we calculate a standardized FLR, the FLR was 25.7, and post PV, this increased to 31.4. So using this, we get a degree of hypertrophy of 5.7% and a kinetic growth rate, that is divided by the number of weeks is 3 weeks. So that is 1.9%. And this is acceptable liver regeneration, with which we can proceed for surgery. So we assessed the patient according to protocol before surgery, and we noted a mild rise in the AFP from 31 to 61. And after fitness was obtained, we proceeded for surgery. He underwent surgery on 3rd October. We did a diagnostic laparoscopy, which showed a smooth liver surface. There was good hypertrophy of the left lobe. There was no extrahepatic disease. An intraoperative ultrasound was done, showed that the MHV was pushed to the left. There were no other lesions. A right hepatectomy with MHV and caudate lobectomy was done. We did an anterior approach with early hanging and early looping of the left hepatic vein. Now, parts of segment 4 actually could be preserved with good vascularity and adequate tumor margins. This is the line of transection. You can see that we could preserve part of segment 4. The liver remnant, you can see that large left lateral lobe, parts of segment 4A and 4B that could be preserved with a good tumor-free margin. This is the cholangiogram showing the branches to 4, 3, and 2. This is the specimen, and here you can notice a good tumor-free margin. And this is after the specimen was fixed. There's still an adequate margin. Postoperatively, on day 1, we did a Doppler ultrasound, which showed good inflow and outflow of the remnant. The peak biochemistry values were noted on POD1. The bilirubin was 0.9, and this was the peak value in the postoperative course. And the peak INR was 1.88. On day 7, the patient had a low-grade fever, which turned out to be an E. coli UTI, and there was an SSI. So IV antibiotics were started. This was Clavin-Lindo grade 2 complication. And the patient was discharged only on POD 14, day 15. This is because of the SSI and the UTI. We kept him in hospital. The biopsy showed a moderately differentiated HCC, 14 centimeter in maximum dimension, with extensive areas of necrosis, no vascular invasion, occasional lymphovascular emboli, no perineural invasion. The closest margin was 0.8 centimeters. The adjacent parenchyma showed portal triaditis, and a rhodomin stain showed copper deposits in the periportal and the periseptal hepatocytes. On follow-up, we tested the 24-hour urine copper, which was just above normal. The ceruloplasmin was within normal, and a slit lamp examination showed no KF ring. So this, according to criteria, is pretty much ruled out Wilson's disease. The patient was doing well, and the wounds were healing. The liver function was normal. He's planned for regular follow-up with 3-monthly ultrasound and AFP, and we planned a cross-sectional imaging at 6 months. So what are the lessons that we learned? One, as it's known, multidisciplinary teams help in converting more patients to curative intent treatment. And TACE PV can augment the FLR while avoiding tumor progression in the interim period and has a safe morbidity profile. This lesion was actually pushing the MHV into the segment 4. Portal vein was done sparing the segment 4. We had actually wanted to embolize the segment 4, but interventional radiology felt that it was not safe. That's why it was spared. And this actually helped to expand the tumor-free margin in the segment 4, enabling us to preserve a major part of it. So in such cases, PV may actually not only increase the total volume of the FLR, but actually it can actually increase the space around the major vessels, which can aid in parenchymal preservation. I just like to acknowledge everyone who's involved in the case. And this is our Onco GI tumor board, which now happens through Zoom because of the pandemic. Thank you.
Thank you, Dominic. It's a very nicely, very beautifully managed case, as per the textbook. Can you hear me?
Yes, sir.
Yeah.
You're audible.
I can't see any questions in the chat box. I think while people are thinking about the question, that's come to mind is, why did you not consider ALPS? What was the reason for not considering?
Here we just needed a modest increase in the FLR because we have a large tumor, and the FLR was actually around 20%. We didn't need to expand it to a huge amount because
the point of ALPS is you have spent you had to spend almost 2 months more than 2 months for this thing. No? So
Yes,
the
sir.
point of ALPS is to reduce it.
Yes,
If
sir.
you get more, so if you know, there's no problem getting a higher increase in size. There's no problem with
Sir,
that.
the problem with ALPS is the increased morbidity and mortality. So we felt that this was a safer approach.
Okay, so that's the question. Is there any evidence showing that ALPS has got more morbidity and mortality compared to portal embolization, TACE portal embolization for HCC specifically?
I don't know specifically if there is a head-to-head comparison, but generally with ALPS and the experience that we've had is that there is an increased morbidity and up to a 10 to 12% mortality. But specifically,
Yeah, I mean, that's
I don't know.
so the morbidity mortality is probably high if you do it for cholangiocarcinoma. In fact, that is where it was tried first, but then subsequently, if you do for that because of the bile leak, etc. But for HCC and for colorectal mets, that could have been an option. Secondly, why did you want to? So anyway, that's okay. It's but that would have been a reasonable option, I think, in this particular case.
Yes,
Second thing is after the taste itself, I think there was a reasonable hypertrophy. Maybe you could have gone for that, but then you took a very safe approach, which is fine, fantastic. And the good point is that it also gives you a very good test of time because 2 months have elapsed and still the tumor didn't grow too much. There was no vascular invasion. AFP was normal. So all those things, they help you select your case as well. So very, very nicely managed. Why did you want to look for Wilson's disease?
We had a non-cirrhotic HCC, and there was no identifiable factors. There was a copper deposit. I think it was slightly more out of academic interest that was followed up.
But I mean, do HCC occur in Wilson's without cirrhosis?
Yes, sir. We found a few papers that showed that you can have HCC in a non-cirrhotic Wilson's also.
All right. Okay, I didn't know that. I thought it occurs only with cirrhosis. There's a question by Ramesh Rajan, why was biopsy done? I think biopsy was done by the previous team before they referred to KIMS. So I think, so was biopsy required, you think?
Sir, actually the imaging finding is pretty, there is arterial enhancement, there is washout.
Yeah.
It is pretty
yeah, I know, because biopsy is not going to change anything. Yeah.
Yes.
Having said that, we've recently had 2 cases. It was slightly atypical. And very recently 2 cases, both of them as biopsy came as lymphoma. Not biopsy. I mean, one we had a biopsy, other one we operated, came as lymphoma, and that's a very, very rare thing. So with an atypical presentation, even this big tumor, sometimes you can present that. So particularly they're elderly patients where surgery is, maybe slightly risky. A biopsy may be useful, but I think this you did the right thing. Any other questions on the chat box? Let me see. Do you think if you had thought of possibility to preserve part of the segment 4 in the initial part of the operation, could the plan would have changed? Yeah.
So this is something we thought of. If we could actually preserve segment 4 initially itself, we could have avoided all of this. But the thing was the tumor seemed to be quite close to the right pedicles and the segment 4. So we thought that if we try to preserve the segment 4, we might risk compromising the tumor margins. So we felt that in this man, he was young, he was well preserved. It was worth giving him all possible benefit.
Yeah. Question from Tony Joseph. In this case, isn't conventional FLR measurement better than standard FLR measurement?
We actually use the standard FLR measurement most of the time. But what happens is when you use standard FLR, it is prone to error. Like if you have to measure the volume of the normal liver around the tumor. And this will actually get increased if you have multiple tumors. I actually sat with the technician and we were calculating this. So it's very prone to bias. Like there are areas around the tumor where it might be non-parenchyma, it might be tumor. So all of these things, you have technical errors. And if you have multiple tumors, this technical error is going to be compounded. The standardized FLR is actually based on the patient's body surface area. So it actually meets his physiological needs better. And it's standardized for height. So in this, and as I showed, there was a calculation error when you use the conventional FLR. So because of this, that's why I presented it with the standardized FLR. And the radiologists use that. And when you want to calculate the degree of hypertrophy and the kinetic growth rate, everything, it comes better with the standardized FLR.
Okay. Any other questions?
Dominic, I'm Ramchandran.
Yes, sir.
Excellent presentation and very well managed case. I just would like to ask one thing. What was the reason? Why did you remove the caudate lobe? Because this is not a cholangiocarcinoma. So you could have preserved the caudate lobe, which probably will add some extra FLR.
Sir, here the caudate lobe was actually involved. Here we could see that the caudate lobe was actually involved.
I think the tumor was involving the caudate
The
lobe.
caudate lobe.
On the CT, you could see that going into the caudate lobe. So I think I must congratulate your radiologist particularly, because the ipsilateral method of portal vein embolization is quite difficult. So I think they've done a really good job for you there. So that's well done.
Thank you, sir.
Hi, sir. Dr. Shabir here.
Hi, Shabir. Hi, Shabir. Yes.
Yeah,
Good job. Good
I
job.
would like
You
to
did
make
very
a
well.
comment, sir. One
Go on,
regarding
carry
this radiologist approach. Actually, we wanted a segment for embolization because we were happy in doing an extended appendectomy, and that segment for inflow pedicle was actually very close. So we wanted to do it. Wanted a very comfortable resection. But actually, what he told us is, in this case, because the pedicle is played, the left pedicle is played, it is very difficult to identify a segment from segment 2-3 portal vein in a 2D photogram. So he actually prevented, even though we pushed him to do it, he actually prevented, he actually didn't do it.
Did that, okay, yeah.
So that was a good feedback from him.
Yeah, he did a good job.
It would have been a disaster if you would have done one lateral lobe branches instead of a segment 4.
Yeah, yes, correct, yeah. But excellent job, Shabir. You did extremely well. Very well protocolized management, textbook management. Very nice.
Thank you, sir.
Dominic, in the histopathology, how much tumor was viable? Did you see any difference after TACE and portal vein embolization? Did you see any reduction in the viable tumor, or a lot of necrosis or something like that?
Sir, there was extensive necrosis on the biopsy, and actually better than that, in the PET CT, you could see large areas of necrosis.
But still there was uptake in the PET CT?
Yes, there were areas. It was only a partial response. It was not a very good response. And our radiologist was, he was not at all happy after the TACE. He was saying that there was a lot of drug runoff. It was a very vascular tumor. It was quite large, 10 centimeters, and there was limited drug that could be given. So the response was not that great, but there was a partial response by M-RECIST criteria. And on the biopsy also, there was extensive areas of necrosis.
Okay. Jaypal, there's a question from Jaypal. Is there any role for HIDA to assess the improvement in function before and after portal vein embolization?
HIDA would actually add to a functional element of the assessment. So it might have helped, but we felt that which was better than the HIDA was actually the assessing the regeneration. And we noticed that there was a regeneration, a degree of hypertrophy was about 5%, and the kinetic growth rate was almost 2%. These are the two cutoffs for a low risk of post-hepatectomy liver failure. So I think that was good enough.
So as an extension to that, let me ask a PG question. So what is a functional scan that is normally done, and what's the physiological basis for that scan?
Okay, so the most commonly done scan is the ICG retention scan. So that is used in the Makuchi criteria also. So what is done is ICG is given, and you estimate the clearance. This can be done by plasma estimation, or
what's the physiological basis? What is it special about ICG that makes you use it as a functional scan? What is it?
It's a marker that is taken up almost exclusively by the liver and excreted unchanged. So it will give you
how much is excreted?
So we look at how much is excreted classically. At,
so it's completely. So two things. One is it's completely taken by the liver.
Yes,
secondly, it's completely excreted. Any other property that's very important? We want to use that as a marker for liver function. There's one more property of ICG that's very crucial, because you're measuring the blood level, right? Any other PGs? Anybody knows? So there shouldn't be intrahepatic circulation.
Okay.
Because intrahepatic circulation obviously will come back into the blood, right?
Okay. Oh, yes.
So it's completely excreted and there is no intrahepatic
Intrahepatic
circulation.
circulation.
Those two properties are crucial.
Okay.
So what about the characters of the tumor itself? That is important for I mean, if there are some issues, then the SCG green doesn't make much use.
So classically, if there is obstructive jaundice, the bilirubin has a competitive uptake at the receptor sites. So if the patient has obstructive jaundice,
obviously, the bilirubin is jaundice, and any other condition, any other flow phenomenon that is. So again, if it is a hepatic or portal vein thrombus, then again ICG green won't be that because it doesn't come into the liver in the first place.
Okay.
So those are two areas where the use may not be that good.
Okay.
So how much do you want ICG green for resection? I mean, how does it?
So in the Makuchi criteria, they do ICG at 15 minutes and they calculate the retention. So if the retention, if it is less than 10%, the patient is fit to undergo a large trisectionectomy. Whereas if it increases to about 40%, that means that the liver function is not good and you should not attempt something more than a small resection or an enucleation.
So less than 15 is good. 15 to 30 means you can go segment resection. If it's more than 30, you can't do anything. That's a sort of rough sort of thing, I think.
Yes.
Any other questions? So one other thing is in the theory of tumors, any other blood marker? I mean, you've done all the viral markers, but any specific viral marker that would be useful? I mean, because what you have done is hepatitis B standard markers, right? Surface antigen,
so
HCV antibody. So which means you're looking for cirrhosis, but without HBsAg negative. So if you're just core antibody positive, also you can have tumors.
So
usually hepatitis C produce tumors already cirrhotic, but hepatitis B can produce tumors without cirrhosis. So which particular group of hepatitis B transmission is highly susceptible for tumors?
So I think vertical transmission. Here we had actually done the hepatitis core antigen because this
core antibody.
Core antibody. Because it's reported that around almost up to 30% of non-cirrhotic HCCs can have occult hepatitis B. So we had looked at that and followed that up when the antibody was negative.
And another PG question. So what do you think were the good prognostic factors for this particular patient and the bad prognostic factors for this particular patient in terms of HCC?
The good factor was actually the pushing margins. It was not an invasive kind of
lack of vascular invasion,
and there was a lack of vascular invasion. We observed him actually for over a long period of time. So I think from July to October, there was very minimal change in the disease, though it had not metastasized or progressed too much.
It's a good point, but then obviously that is something which you cannot use because you can't. Let's say, we cannot say, let's wait for 3 months and see what happens. Obviously, we don't do that.
Yes. So
at the point of
the AFP was only 33. It was not a grossly elevated AFP.
Any other marker that you could have used?
So the other markers would be PVCA or DES. It's a protein induced in vitamin K absence.
What's the other name for that?
DES carboxy.
Des gamma carboxyprothrombin, BCP. So that's supposedly a little bit more sensitive and specific for this thing. So now we do that routinely, I think, and we find a combination of both is very good. Okay, so anything else? Any other?
We can actually do as another tumor, we can do a sub-analysis of AFP, the L3 level, which if
transcranial fraction,
it's more than 35%.
Any other good prognostic markers?
The age of the patient. He had a good performance status, no comorbidities. he was actually fit for surgery. Liver function was good.
I mean, from the biology of the tumor point,
Uh,
anything else
There
that you
was-
can look for?
It was localized. It was a moderately differentiated tumor. No lymph nodal spread. There was necrosis on the biopsy.
So one simple marker is the nuclear lymphocytic NLR ratio, nuclear lymphocytic ratio, neutrophil
Yeah.
lymphocytic ratio.
Yes, sir.
So if that's more than 4, it's supposed to be good. I mean, it's good. It's there for most solid tumors. It's there for HCC as well, because that means there's a lymphocytic response.
Yes.
And that means the ratio will come down actually. So
Okay.
if it's less than 4, it's good. If it's more than 4, it's bad.
Yes.
Then PET uptake that's another important thing. The PET uptake.
PET uptake.
So the PET uptake is again, it's a okay.
Good response.
So I think there's no more questions. I'll just hand it over back to Joshi and Pidambaran. And Dominic, thank you very much. And congrats to Dominic, Shabir, and the radiologist for the very lovely, beautifully managed case. Thank you so much for this opportunity.
So any comments from the senior members?
Who all is there? H. Ramesh is here?
Ramesh sir is not there. Subalal sir is there.
Sir, Shivaral sir, any comments, sir?
We have to thank Dr. Manish Yadav for the excellent radiological work.
Yeah, beautiful.
We have done it only because of him. And the credit should go to him, then only to the surgeons.
Yeah, beautifully managed.
Prakash sir.
No, nothing more to add. It was a very well managed, very planned out, charted out treatment and good outcome. Congratulations.
Thank you, sir.
Ramesh Rajan sir. Anand Kumar sir.
Yeah, well managed case with excellent radiological backup. Well thought out and executed.
Thank you, sir.
So, Raman, I'll hand it over to you.
Thank you, sir, for that good moderation and of that wonderful case. I would like to invite Dr. Ramachandran.
Hello, we will ask Arun to answer the question. No?
Ramachandran, can you see the slide?
Yeah, I can see your slide.
We can see.
So it is basically for a postgraduate. Any comments? One basic question. I think during our MS time, we learned all the types of this particular procedure.
I think the answer should come from some postgraduates.
This was one of the, I would say, short notes during our MS theory examinations. Okay, anyway, the answer is Heineke-Mikulicz pyloroplasty. And the first response, correct response was from Dr. Pramil K, GA surgeon, Lissy Cochin. Congratulations. And the prizes will be given by Dr. Joshi John and Dr. Ramachandran over courier.
Arun,
Back-
spelling
back-
is the Heineken
yeah,
is right.
yeah, spelling is also very important.
Okay.
Back to Dr. Ramachandran, please.
Arun, one comment. Heineken pyloroplasty is
Sir.
a straightforward answer, but that is usually done in pyloric stenosis or duodenal stenosis. But this is done as a prophylactic. So that prophylactic pyloroplasty, that word also should have been there in the answer.
Yes, sir. Excellent. See, the choice of pylorus management after transhiatal esophagectomy, there are at least 4 schools. One is no pyloric intervention at all. Second is pylororexis. You dilate the gastric tube. Third is pyloromyotomy. And the fourth option is pyloroplasty. So there are 4 schools of thought, depending on the center's experience. The center from which, the teachers who taught us, definitely the choice differs. I don't know, in our unit, we follow a classical pyloroplasty because occasionally we have seen a largely distended gastric conduit full of reflexed biliary secretions can add to pulmonary morbidity in such patients. So it is our unit preference, center's preference. So that is my comment on this, sir.
I would like to ask a question on that. Arun.
This is only a quiz.
No. I am asking a question on this comment.
Okay. Tell me, please.
Okay. So you are telling that there is a lot of bile reflux. That means that the pylorus is patent.
Okay.
Theoretically.
Okay.
So whether
see it needs to be drained well. I don't know. I can't prove myself, but it's a denervated stomach. At least in the initial, it's a denervated stomach. At least in the initial phase, in the initial postoperative phase, it should be drained well.
Yeah, and the most important concern, I think, one important concern is to avoid pressure on the staple lines or on the anastomosis.
Yes, sir. Yes, sir.
So I would also go for a pyloroplasty.
No, I'm not against pyloroplasty or something like that. Only thing is that when I'm told that there is bile reflex, so the bile should be distal to the pylorus. So if the bile is coming back, that means the pylorus is patent.
Yeah, it may be patent, but not enough patent. Not patent enough.
Murli is there in the audience. Murli.
So any other questions? Any other discussion points? Shall we wind up the session?
Okay.
So again, I would like to thank Dr. Dominic, Shabir Ali, and the entire KIMS team for their excellent case, very well managed. Thank you once again. And thank you all the audience, all the participants. So we will meet again next year, maybe in January first week. I think it is 2nd of January. That's our 4th meeting, clinical grand rounds. So wishing all a very happy new year. Hopefully it will be a fantastic 2021. So once again, thank you, Pidambaran, for all the arrangements, and I would like to thank Ethicon for sponsoring this session. Once again, thank you all.
No,
Thank
you
you.
can all go for fellowship and dinner.
At home.
Thank you all. Good night.
Thanks.
Good night, sir.
Good night.
That's sir.